Welcome to the regular Friday meeting of the Portland City Club. I'm Bill Lesh and I'm City Club President. And I'm scared to death, so I hope you will bear with me. It's a little intimidating to see a crowd of over 900 people in front of you when we normally have in the range of 200, and I'd like to welcome all of you here today. I'd especially like to welcome and thank the Board of Medical Examiners for their participation in cooperating with us on this program and for allowing us to share it with them today, and there will be more about that in a moment. With me at the head table today are Dr. Hugh Johnston, our speaker, and John Uwelling. Dr. Johnston is chairman of the Board of Medical Examiners, and John Uwelling is the executive director of that organization, and I would hope you would help me welcome them to the meeting today. We had hoped that Congressman Ron Wyden would also be here to participate in our program, but Ron is finding out what the vagaries of unregulated airline schedules is like. We may find out more about that in his next press announcement on new bills he's introducing. Today's program is being taped by TCI Cable for broadcast on C-SPAN, which is an exciting first for us. We are also, as usual, live on Oregon Public Broadcasting Radio, and we'll have one of those tape delays on KPBS Radio and also on area cable television, so I would hope that you would take a chance to perhaps watch this a second time through. There will be questions for Dr. Koop after his address. We have, because of logistics today, a little different method of doing so. You were handed question forms if you came in. If you would pass those to your left, my right, just to confuse you a little bit, the staff will pick them up, and we have folks here from the program committee of the City Club and our Board of Governors who will be asking those questions. I have the opportunity today to recognize a special organization, and I'd like to ask Dr. Hugh Johnston if he would join me at the podium. I'd like to read a proclamation from the Office of the Governor. Whereas the Oregon State Board of Medical Examiners was established on May 28, 1889 by the Oregon State Legislative Assembly, recognizing that to practice medicine is not a natural right of any person but a privilege. And whereas it was necessary for the health, safety, and welfare of the people to provide the granting of that privilege and the regulation of its use so that the public is protected from the practice of medicine by unauthorized or unqualified persons and from unprofessional conduct by persons licensed to practice medicine. And whereas the legislature has charged the Board of Medical Examiners under ORS Chapter 677 with the responsibility for administering the Medical Practices Act and establishing rules and regulations pertaining to the practice of medicine. And whereas the legislature has determined that the board shall examine, license, and register graduates of medical and osteopathic schools and investigate and discipline violators of its rules and regulations. And whereas the legislature has also charged the board with the responsibility for licensing, disciplining podiatrists, and certifying and or registering acupuncturists, emergency medical technicians 2, 3, and 4, and physician's assistants, and whereas the state of Oregon acknowledges that the Board of Medical Examiners has continued to fulfill its responsibility under the exemplary leadership and direction of its very dedicated board members, committee members, and staff, and extends its grateful appreciation to these people for their many years of faithful service and contributions to the Board of Medical Examiners and to the people of the state of Oregon. Now, therefore, I, Neil Goldschmidt, Governor of the State of Oregon, hereby proclaim October 6, 1989 as the 100th anniversary celebration of the Oregon State Board of Medical Examiners in Oregon and encourage all its citizens to join in this observance. And it's signed by Neil Goldschmidt, our Governor, and Barbara Roberts, Secretary of State. I knew Congressman Wyden would show up after I had the opportunity to bumble my way through reading the certificate. So let me introduce Congressman Wyden. I think he's familiar to most of you. He has represented the 3rd Congressional District here in Oregon since 1980. His long-standing commitment to the elderly and to those in need has led to a strong interest in health care issues. As an advisory board member of the Oregon Foundation for Medical Excellence, which provided support for Dr. Koop's appearance here today, Congressman Wyden will give an introduction of Dr. Koop. Will you help me welcome Congressman Ron Wyden?
Well, thank you all very, very much. It's a pleasure to be home, despite the airline's best efforts to keep me from getting there this morning. And I must tell you that this is really the time of year when you do want to be home and be out of Washington. It really illustrates that old theory that you don't want to watch laws or sausages get made. And that is particularly true right now about Washington, D.C. Dr. Koop, our Surgeon General for 8 years, in my view, embodies what Oregonians feel public service is really all about: independence, uncorruptibility, and most specifically, a full commitment to the public trust. His efforts to shape our health policy on such issues as AIDS and abortion and tobacco shook up complacent politicians and lethargic administrators. And it's my view that because of Dr. Koop's efforts, millions of Americans are going to be healthier in the years ahead. But as I had a chance to work with Dr. Koop as a member of the Health Subcommittee, in particular, I came to feel that his most important contribution was on another front. It was something perhaps more important than any particular piece of legislation or any particular amendment. What Dr. Koop told this country loud and clear is that public health is more important than partisan politics. And you should know that Dr. Koop took a real beating for it. He took a real beating from some of those on the far right. He took a real beating from some who said his position wasn't in line with somebody's political platform, or it wasn't in sync with what the party activists really think ought to be done. If you don't believe me, you can read all about this in that well-known medical journal this week, People magazine. But we saw it constantly on the Health Subcommittee, and I just feel that when it's all said and done, what we want is a Surgeon General who embodies the qualities and the integrity that Dr. Koop has provided, who says loud and clear that I'm here to promote the public health and not partisan politics. And I have to tell you that I'm not sure I would have gotten up at 4:30 in the morning for just about anybody. But Dr. Koop is very special. Let's welcome him to Portland.
Thank you. Thank you ever so much. Congressman Wyden and Dr. Johnson, ladies and gentlemen, it is really a delight for me to be here and to be here on this specific occasion when you are recognizing the 100th anniversary of the Oregon State Board of Medical Examiners. The last time that I addressed an audience in an auditorium quite like this, with balconies up there that I cannot quite see because of the lights, I was looking like this, had my mouth open. That's the moment that photographers wait for, especially if they're on either side of you. And the next morning, there I was, white beard, mouth open, San Francisco Chronicle, just said a few words. Looks like Lincoln, sounds like Moses. So I hope you recognize that you are in the midst of prophecy this afternoon as I tell you a little bit about some of my concerns about this country and its health plan. Not long ago, a talk at this time of day about health care in America would have been a rather pleasant dessert after lunch, something to make us feel good about ourselves and our health care system, but that is not true today. In a word, we have big problems. Sometimes I used to wonder when I was still in office if there shouldn't have been another Surgeon General's warning. The American health care system itself might be hazardous to your health. To begin with, this is a time in which we have very high expectations for medicine and for health. We put a great deal of faith into new things such as technologies, pharmaceuticals, new operations, surgical procedures, and so on. And we continue to have faith in what I like to call the magic of medicine. We routinely expect miracles to happen, even though the real world of medicine isn't always able to deliver. We have that situation right now with AIDS, for example. For the past 8 years, scientists and clinicians have been working around the clock to understand that virus and to conquer the disease of AIDS, but it still remains somewhat of a mystery. I'm sorry to say this, but I do not think we will get control of that virus fully before the turn of the century. But as far as the general public is concerned, they think that the AIDS situation is the exception and not the rule, because the American people still maintain high hopes for what medicine and health care can do for them. But I think it's also becoming clear that those high expectations are fast outrunning our ability to pay for them. In other words, we have a clear gap in our society between what we would like to see happen in health care and what can realistically happen in health care. And so the American people are engaged in a debate in respect to aspirations versus resources. This is a debate that touches many aspects of American life, but I will just focus on health care, which is profoundly affected by that growing tension between aspirations and resources. Many of our great expectations come from our abiding faith in ever-improving medical technology. But now, I believe the public wonders if medical technology might not, at times, be a mixed blessing. Thanks to an explosion of new knowledge in science and technology over the past several decades, we know how to do many things, fascinating things, but knowing how has never always been quite enough for us in America. People also want to know why, or perhaps why not. And today, as the cost of our magic technology soars, we're asking why more often and more insistently. In regards to prolonging life, for example, both the lay public and the medical profession are even now debating the wisdom of using so-called extraordinary procedures, whatever they might be, to save or prolong the lives of persons profoundly traumatized or in a terminal illness. For many people who must decide the fate of loved ones, high-tech medicine sometimes acts like a friend, but sometimes it also acts like an enemy. Hence, some people are turning to legal instruments like the so-called living will or a durable power of attorney in order to protect themselves from runaway medical technology in the event that they might have a terminal illness or condition over which they do not seem to have control. Hence, in many real-life situations, technology is a mixed blessing at best and can be, at worst, a curse. Is our society still ready and willing to deliver high-quality, technology-intensive medical care to everyone, regardless of cost? I'd have to say, on the basis of my travels around the country, that society's answer is approaching a probably not. Or perhaps the most sophisticated medical technology is often simply irrelevant. According to one survey of physicians, the largest category of patient complaints involved conditions without illness. In other words, the average practice, not just that of family doctors, but many specialists as well, has a significant number of patients who are in relatively good physical and mental health, but they just don't believe it. What they want from their physician is some display of reassurance, understanding, solace, sympathy, some demonstration of what Shakespeare called the milk of human kindness. What we have then is a rise in the new technologies available to physicians, but at the same time a decline in their significance for a substantial number of their patients. In one of his plays, George Bernard Shaw asked why we pay doctors to take a leg off when we really should be paying them to keep a leg on. And now almost 80 years have passed since George Bernard Shaw asked that question, and we still haven't come up with a good answer. Our technology-driven reimbursement system, whether by government or out of pocket, is still predicated on taking that leg off. The struggle between our aspirations and our resources has come at the worst possible time, a time when demographic trends are running against us. Today, for example, for each person who is over the age of 65, there are 5 younger tax-paying wage earners to pay for that one person's Medicare coverage and Social Security. In another 20 years, however, for each person over 65, there will only be 3 younger tax-paying wage earners. And they will be in a climate of scarcity when Americans will have to work out some kind of equitable sharing of needed medical resources between one population group that is growing, that is the elderly over 65, and the other population group that for the first time in our history is relatively shrinking, and that is children under the age of 18. Now, over the past 8 years, I have dealt with advocates for both of these groups, the elderly and children, both very dedicated kinds of people, very persuasive, and both will quite rightly, in days ahead, be competing for a larger piece of a smaller pie. Now, this has chilling ethical implications, and I would urge that we guard against letting our ethics be determined by our economics and not the other way around. Now, some critics will say that the chief cause for the crunch is the budget deficit. Once we get rid of the deficit, they say, we will also get rid of that gap between aspirations and resources, between dreams and reality. Maybe, but I don't really think so. Well before we had a budget problem, we already had a healthcare economy that consistently ran at an annual inflation rate that was 2 to 3 times the inflation rate for the rest of the American economy. But we didn't see it, or if we did see it, we chose to ignore it. Today, we still have an inflated healthcare economy, but we also have inflated healthcare aspirations, and we simply can't afford any kind of inflation at all. When I or other people talk like this, our critics come back and say that things really aren't that bad. They say all we need is to put a reimbursement cap on this, or put a little change here, change the eligibility regulations there, cut back some here, prunes things over there. But I can assure you that when I was your Surgeon General, I listened to these debates, and I have thought through the human costs associated with that kind of patchwork approach. And today, I'm more convinced than ever that our whole healthcare system needs to be studied with an eye to making a number of very major changes. Corrections, if you will. I can already hear critics saying, oh, Dr. Koop, the system ain't broke, so don't fix it. But I want to tell you that I think the system is broken and that it must be fixed and that Band-Aids will not do. Hospital costs are still climbing, and no one can prove to the American people, at least, that the quality of hospital-based care is uniformly going up at the same time. On the contrary, our people complain that they're paying more and more for medical care, but they seem to be getting less and less. Worse still, as the cost of hospital-based care increases, hospitals themselves are trying to narrow their patient pool. For example, by eliminating the need to extend inpatient medical care for poor and disadvantaged Americans. I say there's something terribly wrong with a system of health care that spends more and more money to serve fewer and fewer people. And we have much the same problem in respect to physician services and fees. I can tell you that many of my friends and colleagues in medical practice are trying, sincerely trying, to do what they can to increase the quality of care they deliver without increasing their costs. But they argue that they have little or no control over some of the inflationary things that they do. And I think that that's true because I've been there. And it's not just that I am giving them the benefit of the doubt because they are my colleagues. The fact still remains that physician fees are going up, and they do add a burden to the public that is becoming unsupportable. And again, as with hospital-based care, the American people have not been assured in any rational and measurable way that the higher costs they are paying for physicians' care will in fact buy them a proportionately higher quality of care. Now, whether speaking of doctors or of hospitals, it is not a matter of morality. It is survival. Everybody is doing it, whatever it you focus on. The reality is that doctors and hospitals cannot do it, whatever it you're focusing on, or they will fail to survive. The great truth is that the health system will never revamp itself. The change has to come from the environment, and that environment, ladies and gentlemen, is you. Before I go any further, let me say that in general, I do support the concept of a laissez-faire marketplace, and I believe in a freely competitive economy. I think a laissez-faire economy works best for all our citizens, and I'm thrilled, as I'm sure many of you are, to see so many countries with state-controlled economies coming around to our point of view. Now, having said that, let me go on to say that the healthcare marketplace is laissez-faire, but it is not freely competitive. And hence it has virtually no moderating controls working on behalf of the consumer that I much prefer to call a patient. In most other areas of our economy, the marketplace does exercise some control over arbitrary rises in charges to the consumer, and there really is competition. Here and there it might be thin, to be sure, but it does exist, and it does provide some assurance that ineffective, uncompetitive, high-cost, low-quality enterprises will eventually fail. But in healthcare, right across the board, prices have gone up irrespective of the quality of care being delivered or of any other marketplace control. Try as they might, I don't see the medical profession achieving much success in self-regulation. Granted, it is no simple task, but as I said a moment ago, until the purchasing public buys health care right, as Walter McClure puts it, the market cannot change. Physicians can help to put the brakes on some general expenditures, but there are very few physicians who can honestly and effectively control the delivery of service, much less control the costs for that service, while at the same time caring for a specific individual patient at the bedside. We seem to have, therefore, a system of health care that's distinguished by a virtual absence of self-regulation on the part of the providers of that health care, hospitals and physicians, and distinguished as well by the absence of such natural marketplace controls as competition in regard to price, quality, or service. What is the effect, then, of such a system? One very serious effect has been the emergence of a three-tiered framework of health care in the United States. Now, I have heard medical doctors say ever since I've been in medicine, we don't want a two-tier system in America, but we have it. But we also have a third tier. In the first tier, the bottom tier, are upwards of perhaps 30 million Americans, perhaps 12% of the population, who fall between the cracks. And they have no health insurance coverage, they have no high options, no low options. In fact, they have no options at all. They're not old enough for Medicare, they're not poor enough for Medicaid. What then does this healthcare system of ours do for the uninsured? In the vast majority of cases, the answer is very little or perhaps nothing, and they are suffering the consequences. Study after study indicates the correlation between no medical insurance and increasing health problems for those who don't have it. The health problems of the lower tier, if ignored by our society now, will be borne by our society later. Then we have that second tier, And this tier receives a narrow range of basic medical and health services with more or less fixed levels for reimbursement. This is low option coverage. This is Medicare and Medicaid coverage, with the patient paying many costs out of pocket or with the help of some form of supplemental insurance, which in my book is another kind of out-of-pocket expense. And then finally, we have that top tier, the third tier, and the people in this tier, probably most of us in this room, receive a full range of medical and health services. They are covered by high-option health insurance and also have a few dollars left over to pay for the 15 or 20% difference between the actual bill from the doctor or hospital and the check that comes in from the insurance company. Many of our largest business and industrial organizations are in this top tier. Years of tough collective bargaining made it possible for millions of their unionized employees and their families to be in that top third tier. But now it's no secret that healthcare inflation has become the major sticking point in their collective bargaining also. And how does this bargaining end? Well, I'll tell you, it's easy. More money is promised for the employee health benefits, and the increased health care costs translate into higher prices for the customer or for the utility ratepayer. In other words, employee health insurance plans have really become pass-along mechanisms through which dollars are passed along into the healthcare system. It's been working that way now for the past 20 years or so. I don't think Americans can keep feeding that healthcare system quite the way we have anymore. We have got to make some changes. And business itself is finally coming around to understand this. It cannot continue to bury inflated costs of healthcare in the price tags of their goods and their services. Since 1984, the average premiums for employer-provided health insurance have approximately doubled. Last year, they were $3,117. They've risen from 8% of the business payroll costs to 13.6% in 1988. Now, businesses cannot absorb those costs and also expect to remain competitive. American businessmen and labor leaders are finally coming to understand what this means. There is a health benefits surcharge, if you will, on every car that General Motors manufactures in this country. It amounts to about $600 per car. In contrast, cars made at the new Nissan plant in Tennessee, the health benefits surcharge is not $600, it's only $60. The General Motors health care plan is a very generous one, and it covers retired employees as well as those in active service. Nissan, on the other hand, offers a limited plan that does not even provide maternity benefits or pediatric care for the children of its active employees. But while economic pressures make business consider cutting back on the health care benefits they provide, social pressures, on the other hand, compel providing even more. We have seen current labor disputes focus on health benefit packages and not wages or hours. The recent telephone strike was a perfect example of that. I'm reminded when I talk about these things of the recent report of the National Commission to Prevent Infant Mortality. Among other things, that commission recommended that the American people must provide universal access to early maternity and pediatric care for all mothers and infants. In other words, let's get rid of any and all barriers to health care for each and every mother and child in America. I imagine you don't know that of all the industrialized nations, only the United States does not guarantee access to basic health care. But this recommendation I just mentioned amplifies the concept of access to a new and very important level. It says that employers must make available health insurance coverage that includes maternity and well baby care. Now, that commission was composed of evenly balanced, I think, physicians and non-physicians, Republicans and Democrats, federal and state officials, and so on. It is hardly a radical bunch by anyone's standards. Yet the members came out for a much greater role for private employers. Now, why would they do that? because today, of the more than 56 million American women of childbearing age, almost 28 million of them are employed full-time in America's workforce. That's 50% of all women in that crucial childbearing age group. In addition, well over half of all mothers of small children, that's kids of 3 years or under, are working full-time in the American workforce. So on a day-to-day basis, it is now clearly the managements of business and industry who exercise the most critical influence on the health of America's mothers and children. The healthcare system in America today, I believe, is a terrible moral burden for our society to bear, in that the system does not respond at all to as many as 12 to perhaps 15% of our population. But it is also a terrible economic burden for society to bear, in that the system satisfies its own uncontrolled needs at the expense of every other sector of American society. And we need to change that system. Not just a little change here, a little change there. We need to bring about a profound change across the board in the way we make medical and health care available to all of our citizens. The question is, can we do it? I'd like to think we can, because we have to, and especially because in similar circumstances we have done things like it before. About 50 years ago, we Americans knew it was morally wrong for our society to allow its old people to drift into poverty and starvation. We knew that we could no longer stand by helpless in the face of such human misery. And so we enacted a Social Security law to make sure that every American would be assured of a measure of human dignity and respect in his or her twilight years. It was an act of fundamental decency. We knew we had to do it, and we did it. And we had a similar challenge more recently than that. Back in the 1950s and early 1960s, the people of this country became painfully aware of the terrible unfairness of what was called separate but equal education. And so, through our courts and our legislatures, we released America from a crushing official legal burden of segregated schools. That's over, and thank goodness that it is. But did we get rid of those burdens once and for all? Well, you know as well as I, not exactly. We haven't yet solved every problem associated with growing old in America, we know that. And we certainly haven't yet produced the perfect egalitarian school system, we know that too. But at least we have lifted from the shoulders of our people a large measure of the burden of shame and guilt that came with doing nothing. We did what was morally right for this country, and I believe we can and we must do that again. Let's finally say what we've hesitated to say for too many years, and that is our current system of health care is just not fair. It's not just, and therefore it is not the morally strong system that our society needs and I believe deserves. We are now at a crossroads. We can't afford to do nothing, to continue business as usual. The pressure for radical change is coming from all directions. It's coming from members of Congress, from business, from labor, but it's also coming from the general public. Increasingly, we hear the demand for restructuring the financing and delivery of health care in the United States. Even some business leaders who normally cringe at the thought of government intervention or regulation find themselves calling for a system of national health care as a solution to rising insurance costs. Now, I just bet that most of you who've heard what I had to say think I'm here plumping for another governmental entitlement. I want to tell you I'm not. But if we don't offer something better, we are going to get cost-controlled medical system and lose forever the present potential we have for the best health system in the world. There are three alternatives. Only two of them are usually mentioned. People will talk to you about this and they'll say, well, we can do one of two things. We can present a system without universal coverage, or we can have universal coverage with government controls. Now, when these two choices are given, a nice, fair audience like you are would choose, reluctantly, the governmental control system. There is, however, a third choice, and that is universal coverage with reform of the consumer or patient choice system. Recently, as I have traveled around the country, I have noticed a strange interest in the Canadian system. Everywhere I go, people say, we need the Canadian system. And I have come to ask them all the same question: tell me, what is it about the Canadian system that you like? Their answer is almost always the same: I don't really know, but it's a good system. Now, the growing infatuation with some foreign national health service is based more upon dissatisfaction with our system than upon the understanding of another one. Most Americans do not realize that a national health service like the one in the United Kingdom is based upon planned scarcity. Experience the world over, ladies and gentlemen, has shown that when government exerts economic controls and when they are applied to health, they prove in time to be detrimental. Eventually, there is an erosion of quality, of productivity, of innovation, and certainly of creativity. Then comes lack of responsiveness to patients' cares and needs. The Canadian system, for example, is not controlled by physicians any longer. It's controlled by bureaucrats. And finally, at the end of the road, comes rationing and standing in lines for care. Americans do not patiently queue up for anything, especially for medical care. We have become accustomed to available care, if not accessible care, and we also desire very personal care. Now, it may not be possible to have the same personal relationship between doctors and patients that your grandparents had. Today, urban people especially rely upon emergency room care and group practices, and the efficiency they bring have come at the cost of that old personal relationship. But we can do a lot to restore the doctor-patient relationship, a relationship, unfortunately, that is becoming changed to a provider-consumer relationship. I realize that there are some built-in problems. People aren't happy about being ill, needing to go to see a physician, and then especially having to pay a high price for it makes it even more unpleasant. But we need to subordinate the economic aspects of the relationship to the climate of trust between the doctor and the patient. If the patient thinks of himself primarily as a consumer, getting the most for his money, he automatically puts the doctor in the role of the seller, getting the most for his services. If the doctor is primarily concerned about collecting his fee, he automatically arouses the consumer mentality in his patient. We also need to reform the malpractice mess, the tort system that forces doctors and patients to view each other as eventual legal adversaries. We need to get past the standoff between doctors and lawyers. I've often wondered if perhaps a committed group of retired lawyers and doctors, men and women without a personal, direct economic stake in the system, could perform a tremendous public service by adjudicating claims, deciding which cases should go to court. I'm sure that both the doctor and the patient would prefer to have that old relationship of trust they used to have, and I am one who believes that it can be restored. But it will take a commitment of people on both sides of the stethoscope. The fallacy of economic controls is that you attempt to force change and reorganization against the will of those who are providing health care. It is not in their own interests as they see it because, and listen carefully, the more inefficient that provider is, the more revenue he receives regardless of health produced. There is a better way, I've mentioned it, and it prevents further intrusion by the government into the delivery of health care. Purchases of health plans, that is, those of large corporations and businesses who make it their business to seek out the best for their employees, must choose health coverage that rewards quality and productivity. The savings will pay for the cost of those presently without access to health care. But there is no quick fix, ladies and gentlemen. If I could plan this system the way I'd like to, I think it might take a decade to accomplish, but we would improve all along the way, day by day. And eventually, every American would be able to expect and receive adequate health service anywhere in this country. Putting together such a morally strong and fair system of health care will be a major task for America. I have absolutely no illusions about that. But we must not let such considerations stop us from doing what we know is right. Thank you very much.
Thank you, Dr. Koop, for a fascinating address. I especially like the part about committing a group of doctors and lawyers. I've got several names I could give you to start the list. We will now move right into our questions. I'll remind you again that we need written questions. Would you pass them to your left, and the staff will pick them up and forward them to the program committee and board members who will ask questions. Our first question today will come from Alan Oliver. Alan?
Dr. Koop, if you had an opportunity to suggest 2 healthcare priorities for the Bush administration to focus on, what would they be?
Number one, the biggest and the most generic, is that we have to pay attention to the general subject that I was addressing this afternoon. I've suggested to the President ways that that might be done by a presidential commission, and the reason I've suggested that is that we have 3 commissions going now, and some of them have been going for as long as 3 years about health care, and we have the new Pepper Commission, and we have a new one that Debbie Steelman is in charge of. But there seems to be, coming from those commissions, a great deal of rhetoric, and I think they will be excellent reports, but I think that they will eventually be shelved. The great advantage of a presidential commission, where you have Republican and Democratic congressmen and senators working members of that commission, is that they develop a proprietary interest in the findings of a commission, and they are the only people in the position to take those findings back to the floors of Congress, and they are to start the debate that will eventually result in some decisions. So I think that is number one. I think the thing that Americans would like to see happen most is for the administration to take a stronger role of leadership in the things that they think are troubling America most in reference to health, and that would be drugs and AIDS.
Cheryl Warren.
Dr. Koop, many liberal groups opposed your appointment as Surgeon General. Women's groups who feared an anti-choice stand on your part, and gay rights groups fearing an insensitivity to AIDS. Yet you played a key role in bringing the AIDS epidemic to national attention, and you refused to support some Reagan administration attempts to restrict abortion. Did your views change during your tenure as Surgeon General, or were these groups mistaken in their assumptions of your views?
Well, they were obviously mistaken. No, it's been a fascinating time to watch all this happen, and as I was telling the gentleman over here on my left before we came out, although I was part of that history as it was being made, I wouldn't be able to tell you exactly how it all came about. I think it has to do with labels. I hate labels, and when I came to Washington, I was the same person I am now, exactly the same person. And I had a label of being certain things in the minds of certain people. And when issues came up, they expected me to react the way they would have reacted if they carried that label. Well, inasmuch as I didn't carry the label, I reacted the way C. Everett Koop always did. My doctor happens to be the director of the AIDS program at the National Institutes of Health, Dr. Tony Fauci. He says I'm the most predictable man in Washington. He says, just tell me what the problem is and I'll tell you how Chick Koop would react. And that's exactly right. I have really only done two things, and because they are such simple things, I'm somewhat embarrassed when people tell me I'm a folk hero or have such courage. I have done, as Surgeon General, what Congress mandates that I should do, and I did it as honestly as possible, and I let the chips fall where they may.
Jean DeMaster.
Dr. Koop, what is the single most important thing that government in general and that individuals can do to promote public health?
Well, I think people have to recognize that public health is different than private medicine. And public health has to do with the health of all of us together, because your health influences me, my health influences you, from some simple things as passive smoking to the fact that what it costs you for health care, because of imprudence perhaps on your part, I have to pay for eventually in taxes. So it can be put in the simplest terms that Americans can contribute best to the public health of this country by taking charge of their own health futures. And that means adjusting their lifestyles in accordance with very well understood principles. And they have to do with such things as no smoking, alcohol in moderation, exercise and diet appropriate for age, checking on certain things that only your doctor can do for you, like your blood lipid level, your cholesterol, your blood pressure, and avoid stress when you can. And with that, all of the problems that people associate with aging do not have to be there. I think one of the saddest things in America is the number 65. I've gone way past there, and I feel much better now than I did when I was on the other side of that pinnacle of 65. But if people 45 today just did what I said, paid attention to taking care of their own lifestyles, when they reach that magic age of 65, instead of it being the pinnacle that meant they now go downhill, they could stay up on that plateau and maybe just fall off the edge many years later.
Ellen Heltzel.
Dr. Koop, I presume that you will agree with the premise of this question. Why did the best Surgeon General leave his post?
Simply he wasn't asked to stay. I honestly should say that if I had been asked to stay on as Surgeon General again, I would have turned it down. I think there comes a point of diminishing returns after 8 years, and I really think that I could do more of the things I'm interested in the private sector without the government portfolio, without government constraint, than I could if I'd stayed in. One other thing that's a corollary to that, I think it is well known that I would have liked to be the Secretary of Health and Human Services. I would have liked to be in President Bush's cabinet, primarily for a reason that most of you wouldn't think of, and that is to try to elevate the position of health in cabinet status in this country. I don't know any industrialized nation that gives enough attention to health. In every country that I have visited, and I did a lot of that for you in international health while I was Surgeon General, there are several departments that always take top billing, and they're understandably up there for good reasons. They're state and defense and treasury. But in most countries, everything else comes in at the very bottom is health. I have the definite feeling that if you want economic prosperity in countries, you have to give health prosperity first and not the other way around. So I would have liked the opportunity to do that. But let me make it perfectly clear. People said to me, suppose you don't get the appointment. What will you do? How will you feel? And I said very honestly then, and I still feel it now, I'll be disappointed for 2 or 3 days, but happy the rest of my life. And I feel even more so when I see what seems to be tremendous inertia at the present time in this administration. And while they're getting ready to shift gears, I'm already in high and ready to go.
Clark Worth.
Dr. Koop, what can persons with HIV infection do to improve care by working within the system or outside the system?
Well, I think they have to use anything that's available to them. I have several comments to make in general, inasmuch as most people who have AIDS have gotten it by doing things that most people do not do and do not approve of other people doing. The people who are HIV positive start off in this milieu with several strikes against them. There is the great temptation when you are facing death, and people who are HIV positive are facing death. We don't know when, but they're facing it. There's a tremendous, I guess it's frustration at the slowness with which bureaucracies move, such as with the approval of drugs and so forth. But I think it is very important for the people who are in those classes of patients who are most usually afflicted with this virus to recognize that the public in America has great difficulty in sorting this out. And therefore, I have always urged people in the homosexual community not to confuse gay rights with the issue of compassion for AIDS patients. I don't think the American people can sort that out right now, and I think if we want the immediate issue taken care of, compassion for patients with AIDS, we ought to let other political agendas go for the time being. But I would remind you that the problem is not so much with those who have HIV positivity, but the rest of us who are on the outside and don't. We have to open our hearts and minds to this situation. We have to remember that we are fighting a disease and not the people who have it, no matter how much we approve or disapprove of the manner in which they got this problem. So that it is not so much what they can do as what we can do. And I think that we take a tremendous risk of losing the social contract that has been so precious to us in this country over the past 200 years if we begin to exclude people in our society, drug abusers or the children of women who had AIDS, even homosexuals, if we try to exclude them from the general healthcare system. That would be a tremendous mistake.
Dennis Cusack.
Dr. Koop, how do you suggest we, as a society, reconcile our expectation of unlimited health care with the reality of limited willingness to pay as individuals in that society?
I don't think we can. I think that's what I've been trying to address this afternoon. I think that gap between reality and dreams, between aspirations and resources, is an ever-widening one, and I don't think that the forces exist to pull them together. Cost containment is extraordinarily important, but cost containment should not be mixed up with governmental economic controls. They are not the same thing at all. And I am fully convinced now that if the major companies in America, who are the largest purchasers of health care, in their separate communities, went to those who provide health care, whether they be Blue Cross Blue Shield, HMOs, preferred provider organizations, and so forth, and bought for their employees those plans which would guarantee the most quality and the best productivity, I think the marketplace would adjust itself so that anybody else who wanted to keep up would have to be competitive. In other words, instead of rewarding the healthcare system with more money, you reward them with more patients, and you send them the patients because they deal with them in a quality way and they deal with them efficiently.
Pamela Rapp.
Dr. Koop, in your view, what was the Reagan administration's most significant public health policy accomplishment?
Wow. Appointing me as Surgeon General. No, I'm being facetious, and you're such a nice audience, I think you understand that. Let's just talk about AIDS for a minute. You know, I travel around the country a tremendous amount, and up until the end of May 1987, I took a tremendous lashing from the press because of what the administration wasn't doing about AIDS. What they really meant is what the president wasn't doing about AIDS. And I had to remind the press over and over again, it is not the president's role to do that much about AIDS. He had a very good system behind him. He had a good Surgeon General, a good Assistant Secretary for Health, a good Director of Health and Human Services, a tremendous organization in NIH, a tremendous organization in the Centers for Disease Control. And although it may seem to you sitting out there, from what you read in the papers, that the progress from 1981 to now about AIDS has been very slow. It may be slow, but if you realize the unbelievable enormity of the virus that we are fighting, what it is able to do, and the fact that we knew nothing about it until June of 1981, we have really done a tremendous amount. And we did a lot of that because we had done research on cancer, and all of the work that had been done on recombinant DNA made it possible to do the things we did with AIDS, just the way 20 years from now, some other knotty problems will be resolved because of the amount of money and time we put into the research on AIDS. So I think that the Reagan administration gets a bad rap about what it did for AIDS, just as an example, when I think the administration, which is all of us who worked under that president, I think we did a pretty good job.
Isaac Regenstrife.
Dr. Koop, the question I've really wanted to ask for a number of years is, where did you get that great uniform? But a little more seriously, be interested in your comments on the Medicaid proposal, which was recently passed in Oregon, creating a system which would provide more indigent citizens with basic levels of health care, but would reduce the level of health care for some people within the system.
Well, you can argue that both ways. It's good for those who get the added benefits. It's bad for the others. I think that's one of the problems, because Medicaid is a beautiful example of a controlled economy, government operated, operating as that middle tier that I talked about among the three that we have. The inequities that have arisen and now have been corrected by creating other types of inequities could be eliminated by the system of free enterprise, where plans for health delivery are rewarded by patients and not by money. It's a big, big problem, and that's a very quick and perhaps glib answer. That uniform I bought myself, by the way, and I told some of your colleagues earlier that I have spent $2,000 of my $200 uniform allowance.